been holding hearts before charts, before meds had names, we had compassion. This one's for every nurse, past, present, and future. Let's go.
We are the calm in the storm, the beacon of hope. Every beat, every breath, we honor the oath. From night shifts to day breaks, loving our tone. Peplau taught us, connection heals more than alone. From Florence to futures, we redefine care, not just meds and machines. We're presence of prayer, with hands that comfort, eyes that see truth. Healing ain't a chart, notice what we do. We are nurses with hearts wide open.
Welcome to the next episode of Peplau's Ghost. My name is Dr. Dan Weisman. Thank you for listening. Thank you for joining us. I'm really thrilled to have our next guest here, Dr. Elizabeth Francis, who we were just talking about. This is a time of year in which a bit reflective about our time and graduation and in the month of May and everything like that. But I think she's graduated and she's done a ton of work since graduating from Duke University. So I am joined by my esteemed colleague, Dr. Sean Convoy, and Dr. Melissa Chapman Hayes, of course, is here as well. So Dr. Elizabeth Francis is a standout alumni, current faculty member at Duke University, a top-tier DNP PMHNP program. She is an author, clinician. She's on the American Psychiatric Nurse Association board member, and truly embodies what we hope that I will be one day as a PMHNP. She's done a great work in really marrying the roots of her emergency medicine experience and really look to kind of connect this with trauma, schizophrenia, bipolar disorder, and so forth. So thank you very much, Elizabeth, for being here. So you've spoken, a lot about this in psychiatry as being both an art and a science. And obviously, Dr. Peplau, Hildegard Peplau, was very much a part of this as being, integrating this into the hope and such, and how this can be, nursing is an art, it's a therapeutic process. So how did you get into this work? You mind kind of just catching us up what kind of brought you to this place in your life?
Yeah, I guess the question would be how my doctoral training at Duke, helped blend high-level neurobiology with the deep human interpersonal art of psychiatric nursing. My coursework at Duke was difficult, as Dr. Convoy will tell you. It was quite rigorous. But also, what I tell my students is, as far as psychotherapy and integrating that with neurobiology, I tell people that the brain is experience dependent. So we have those these repeated emotional experiences that shape our neural architecture. And we learned about this in school, but how psychotherapy and integrating that into my practice that can provide that, I don't know how to say it, the corrective emotional and the cognitive experiences that can gradually rewire these maladaptive pathways. So being able to integrate all of that together is really important.
Yeah. Do you mind kind of going back a little bit and just kind of sharing kind of maybe I'm stealing Sean's question, but just really, what sort of things drew you to this? I mean, what were your experiences like, either personal or professional, that kind of seemed to make sense and kind of lined up to what you were doing at Duke and things?
Oh, why I became a nurse practitioner?
Sure.
And
Yeah,
why I did psychiatry.
Love it.
I had some personal experiences with family members really deeply struggling throughout my life that lived in the home with me. That kind of brought me into psychiatry in general, throughout grade school and high school. So that's what kind of brought me into psychiatry in general. I witnessed suffering firsthand with family and friends, and I wanted to get into a field that I was passionate about and help alleviate that suffering from people that I think our society kind of casts aside and doesn't believe the best in or labels very easily and quickly.
Well said. Thank you. I'll turn it over to Sean.
Hey, Doc. So as we've talked about a lot in the past, I tend to think of psychiatric nurse practitioners kind of being a genotype, and every psych NP that practices and follows is a phenotypic expression of the genotype. Two questions for you. One will build upon the other. First question is, if you are forced to give your elevator speech to say, what is your phenotypic expression of the psych NP role? What's unique about you and the way you think? How would you answer that?
I would say I'm infinitely curious. And in the clinical setting with my patients would describe me as humble and I have a really high ability to tolerate complexity, both with just with the entire person. I have a very high tolerability of complexity of the brain, of a psychiatric presentation, and including the whole person.
Cool. Building upon that, and imagine, if you will, the ghost of Hildegard Peplau hanging over your shoulder. What parts of your practice would she be particularly excited about?
I would say my ability to create a safe therapeutic relationship with patients. I've had students tell me that, and I do believe this, that I'm pretty good with like meds. That's like kind of my thing. But also, I think that my patients come back and refer to me and recommend me because of the relationship that we have, the therapeutic alliance. And like you hear that in school, like I know you told us that, Sean, all the time. But in clinical practice, that is truly what I'm seeing time and time again. They trust me, and I have good relationships with a lot of my patients.
So those of you right now, you can't see this because this is an audio podcast, but just imagine me smiling like a Cheshire cat. So I'm going to pass it to Melissa.
Flattery, Sean. So, Dr. Francis, I want to build upon that, relationship building, and think about a time in your life when you've spent a lot of amount of time in the emergency departments, which would make it challenging, or a different challenge maybe to establish that relationship. You recently published some research on implementing substance use disorder in the emergency department. So in a chaotic, high acuity environment like that, the orientation or getting to know you phase of a patient happens in seconds. What did that teach you about rapidly establishing a therapeutic, secure connection with a patient in crisis?
I saw that and still say it's not just about like, yes, it's very highly dynamic and fast paced, but it's not just about what you say to people, it's how you say it and like the presence that you bring into a room. Like I really try and mix like a confident presence with like a soft presence. Like they know that I get it, but that I'm infinitely present and they have my full attention, if that makes sense. So like while in the ER, you have to be quick. And like I said, it's very fast paced, but being able to bring that type of presence into the room is extremely important.
You can imagine in an emergency situation, you would want someone who has confidence in his decision-making while also having that softer, welcoming presence. Thank you.
Mm-hmm.
Yeah, this is great. Thanks, Elizabeth, for this perspective as well. Doing kind of, as we said before we start recording, a little bit of our online cyber sleuth thing. I found out that you have an interest in metabolic psychiatry, and you've published on this in part of your research. And for those who don't know, metabolic, psychiatry is really kind of looking at your diet, your metabolism, ketogenic diet, and how this kind of affects the neurobiology process. Thinking about this and how we connect it to Hildegard Peplau and the whole person, how do you kind of integrate all those aspects within your appointments and how you care for people, not just, focusing just on the metabolics, but also that relationship piece that you were talking about earlier too?
Mm-hmm. So I ask all of and I always have before I got into like the metabolic psychiatry, which, I've been following the metabolic psychiatry field since 2021. I remember I was in Alaska talking to a preceptor about it when I was in clinical. But I ask all of my patients about their diet, and I always have. And that's just part of like that whole person piece, right? Asking about like what their eating patterns are, what are you eating, which is a direct correlation with as far as metabolic psychiatry, and that part of that umbrella is the ketogenic diet, those kinds of questions with patients, and opening up that conversation about how that directly, your diet has a bidirectional relationship with your mental health and your brain health.
Do you see that helping with that nurse-patient alliance, or do people sometimes push back on that? Like, I'm here to talk about my whatever, not my diet and things like that.
I wouldn't say I've had people push back. I've had people say nobody's ever asked me about that before, which is quite infuriating in my opinion. But no, nobody's pushed back, but I think that they're surprised and curious as to why I'm asking. And I tell them there's very calculated and deliberate reasons why I ask you the questions that I ask you in a 30-minute visit.
Thank you. Appreciate that.
So Elizabeth, you cracked the seal on Alaska, so I got to ask you a question or two about that. So can you for the audience, and recognize that the audience is probably 50-50 pre-licensed or nurses who are aspiring to become nurse practitioners or established nurse practitioners in psychiatry. Can you give us your elevator speech that describes what the experience was like in Alaska for you, and then speak to how that might have influenced the decisions that you make as an independent practicing nurse practitioner today?
Alaska was incredible. It was the best thing that I could have done for my clinical experience. Something, how it influences my current practice, I would say, is how the suffering that I witnessed there, just in ways that I had never seen before, just the profound suffering with the degree of mental illness, but also the lack of just social supports, was jarring and difficult to manage. And I would say now currently how it just changed my perspective and how I practice. We cannot discuss mental health without discussing housing instability, financial stress, systemic inequities, trauma exposure, social isolation, the list goes on and on. But yeah, it was an incredible experience. I wish that I could go back and do it all over again.
I'm going to build upon that, Elizabeth. Can you spend a little bit more time just talking about your exposure to the ACT team model through Alaska Behavioral Health Services?
Yes. So essentially what that looked like was I would get in the car with my preceptor, the company car, and we would go, and he would be like, okay, this person we need to give their Invega injection to, and they normally hang out behind the Taco Bell dumpster in an orange tent. Literally, these were the words being said to me. And so I was like, this is my first day, and I'm like, oh my God, this is crazy. This is crazy. And anyway, we would go do that, and it'd always be quick appointments. And these were people that if you were on the ACT team, you either had bipolar 1, it usually was schizophrenia spectrum, somewhere on that spectrum is most of the patients that we saw. So that's just one example. We would go into the community centers where people would sleep and do their appointments there. But yeah, most of them were on injections, which is really good. I'm a big fan of the LAIs, but yeah.
Thank you. Before I pass this to Melissa, I'll just share, our relationship with Alaska Behavioral Health has been kind of defining for our program, so we're super grateful for them. In my time and trips up there, as I provided support to students, I wanted to share something that I thought was really relevant here. That we think about that population of individuals up there, disproportionately high number of people with serious mental illness, significantly high rates for substance use disorder, dual diagnosis presentations, in one of the most austere environments in our country. And you can get lost in the realization that, wow, there's so much illness here. But at the same time, one of the things that I got watching these patients is that's not all that's there. These individuals find a way to continue to physically survive in some of the most austere places. And I keep thinking, wow, we don't want to just focus on what's wrong. We have to remind ourselves what's still right. I remember being in some of these less than austere places behind the dumpster that Elizabeth was talking about, where I was like, I don't know how physically this person is as good as they are. And then I worked with one of the preceptors who said, yeah, I recently got a lab panel on them, and their cholesterol is better than mine, and their blood sugars are fantastic. And I'm like, wow, there's something in here that we can build upon. So thank you for that, Elizabeth. I'll pass it to Melissa.
Yeah, thank you. In keeping with that whole person perspective that has flowed throughout this conversation, in your private practice, you emphasize personalized care, including advanced practice like hyperbolic tapering to those looking to safely reduce psychiatric medications. This requires, of course, a massive amount of mutual trust and just deep clinical attunement, and then shared decision-making. So how does this highly individualized approach embody Peplau's vision of the patient being an active participant in their own healing rather than just a passive recipient of care?
In regard to the one-size-fits-all, or it's not a one-size-fits-all with the hyperbolic tapering, I'm really passionate about that because we learn all about how to start medications, but not how to safely land the plane. Getting people off medications when it's warranted, because there are people that can come off of their medications, after some time. So, having that conversation with patients and explaining, what the process would look like generally, giving people options too, like this is how we could go about this. I really practice and I teach my students to to give people options. So this is one way that we can approach this. Here's one medicine, here's the risks and benefits. We can also do this instead of a medicine, or here's another medicine. I really try and give people 2 to 4, you don't want to overwhelm people with options, but evidence-based options, and let them decide. And I've gotten feedback that people really appreciate that, because then it's them deciding, but it's also you giving evidence-based options of different ways and I tell people we can get to the same endpoint, Zoloft or Lexapro, or, this supplement versus this, or this therapeutic modality versus this one. But this individualized approach and this, the patient being an active participant in their own healing, I think that's what leads to the healing, is if they're the active participant. You know what I mean? Because I've had patients before tell me that the provider just told me what we were going to do. Oh, we're going to just do this medicine and this. And it's that's why they were in my office or another provider's office, that why they were switching was because they felt like they had no say. So it goes back to that therapeutic alliance, right?
Developing that locus of control and agency has to be a critical component in them managing, themselves in a new way in partnership with their therapist. Thanks.
I love this. I'm going to actually come back to the Alaska thing, because I was thinking in my head, that was such a great experience. And when I saw that you had this experience in Alaska, I guess I had wrongly assumed that you lived in Alaska. But so how does this, did you? Are you from Alaska?
No, I wish I lived in Alaska. That would be a lot of fun. I very much considered it after I left. And so did my colleague that I went with. We were both very much considering it.
So it really touched you personally and professionally, it sounds like, as well. But I guess, take from me, since I'm not from Duke, and maybe a lot of listeners are not either, how does that experience come about? Did you find that experience? Sounds like Sean was part of that as well. So how does that kind of come about as far as that? It's all
through Dr. Convoy there. He and Duke has a relationship with Alaska Behavioral Health. So they will send a couple of students per semester generally. Sometimes I think there's an application. I don't even remember how I got selected. There's an did I do an application? Oh, I did. Okay. I guess I did an application and got picked to go.
It wasn't too hard then either. You don't remember it.
I don't know. Yeah, it was in 2021. So yes, there's an application process, and they pick a couple of students to go. You stay in a townhouse kind of vibe in Anchorage, Alaska, for 4 weeks, 6 weeks, 8 weeks, or longer, depending.
Yeah. That's great. I mean, it's quite a commitment, I would say. I think, I talked to a lot of students too who, not to be too cynical of students, but, they complain sometimes about driving too far to their preceptor site. I mean, going, really kind of halfway across the continent to go to a site that's quite a commitment. But I obviously see this happen again and again, is that good clinical sites can really change your whole life. I mean, your whole perspective here. So thanks for sharing that with us. Now, in moving, from student to now, adjunct professor and on the APNA board, maybe this is kind of a little bit of, take a step back and kind of see, you're young in your career, but what sort of things do you hope that your students get from you when they kind of have those experiences, or people who join APNA and see that you're on the board and see kind of the trails that you're blazing and such? I mean, what are you hoping to be remembered for, and what sort of things are you hoping to pass down to that next generation of PMHNPs?
A couple of things. One is that it's really important. I'm big on policy, advocating for better policies, healthcare policies, because it kind of starts there, And so getting involved is what I would say. I want people to get involved in whatever capacity that they're passionate about. It doesn't have to be the same things that, I do. There's a lot of different ways to get involved and make an impact in that, whether it's nurse practitioner autonomy or different healthcare policy at the, local level, state level, federal level, et cetera. But also, arguably, most importantly, that, I kind of hinted at earlier, mental health conditions rarely, if ever, likely not ever, exist in isolation from a person's trauma, their relationships, their environment, their identity. And kind of tying back with the therapeutic alliance, people, and this is a spinoff of a of a common quote, but it's so true that these patients, these people will often, and I know this because of just personal experiences too, and also feedback, but they will remember exactly how they made them feel long after they forget the exact intervention. It wasn't the Lexapro that saved me. It wasn't, this CBT. It was the way you made me feel. And so that's how I want to be remembered. Like, do people feel seen? Do they feel safe? Do they feel understood? Any sort of psychopharmacological skill that I have, prescribing, skill I have, it's all null and void when you compare it to something like that.
So well put. Thank you. I mean, yeah, it's the analogy I always use is like building a house. You can't build a house on top of a bad foundation, and the foundation is the relationship. And again, I think that's why people are drawn to psychiatry and mental health, is that they like the relationship. They like using, they become the intervention yourself. You use yourself in the appointments and things like that. So very well said, Elizabeth. Thanks.
Mm-hmm.
Elizabeth, I'm going to ask you one final question, and it really focuses about your local practice. Remind me, correct, you're in Kansas, correct?
Yeah, Kansas, Missouri. Yeah, Kansas City, Missouri.
So that area around there, what is it like practicing as an advanced practice psychiatric nurse in terms of practice acts? One of the questions I want to start asking more regularly of individuals who are practicing is, what are some of the unique challenges that you're experiencing? So as it relates to collaborating with physicians and the practice acts within your state, what are some of the challenges? What are some of the successes?
So I'm right. I actually just lived in Missouri, but I live on the border of Kansas. So my practice and business, I have my own private practice and I do a W-2 shtick. I'm on the Kansas side, which is independent practice. So like for my private practice, I don't have to have like a collaborating physician, which is a win. And this is just my personal opinion, I don't disagree with states where you have to practice for like 2 years or something as a PMHNP first. I don't disagree with that at all. If anything, I would encourage that. As Dr. Convoy always told us and burned into our brains, at least into my brain, that I have to teach you how to practice like a psychiatrist in 4 semesters, which is true and scary and also very profound, which is why I do all the things that I do, because I want to know what I'm doing. But also, that would be a big win. I will say on the Missouri side, it is not independent practice, and it is extremely difficult for people to get in and see a provider. And I also see, like for any sort of medications, especially controlled medicines, like people that have ADHD, for example, the physician has to sign off on all of their everything, essentially, the medications, and they see delays in care, but also delays in like getting their medicine on time. That would be the biggest thing that I would say that I see, because I literally live on the border of both of those states, and they're vastly different with those laws.
Great. Thanks. I'll pass it back to Dan.
Yeah, that's we have mirror images. I mean, I live in a border community here for Illinois and Iowa, and so my wife and family grew up in the Illinois side of the community, and so that's where we live. But I jump across the Mississippi River every day and practice in Iowa because of the full practice authority. So yeah, and Illinois has gotten better over time, but yeah, that's the fight continues as far as, feeling that sort of restraint and such. So yeah, I think that the kind of wrap up, maybe just if you wouldn't mind giving your perspective on where is the psych mental health nurse practitioner profession going? I mean, again, you're very well positioned in the APNA board, on faculty and such to kind of guide the profession. Like what do you hope is in the next 5 or 10 years of what a PMHNP looks like, or maybe what you look like in 5 or 10 years? Hard to say.
I hope that I'm even more like, I hope that I'm even better at my job in the sense of like making people feel seen and learning more about different treatments for mental health conditions. Depending on what paper you read, it's like 20 to 60% of the time our medicines just don't work, and 1% of research is spent on treatment resistance. And I hate that term, treatment resistance. It sounds so hopeless, and I don't use that language with patients. But learning more about, I hope that the field is learning more about different treatments like the ketogenic diet, like Spravato or ketamine or TMS, or different interventions that are not medications. But also, I hope that our field is going even more towards and away from, there are some patients that are going to be 5-minute med checks and that's just what it is. And that's fine. But also having our system set up where you get paid more to do a 7.5-minute med check and 4 of those in an hour rather than spending an hour with the patient. I think that that's an abomination. So I hope that the field goes more towards that and emphasizing that, like, the relationship between the psych NP and the person and the patient is not separate from therapy. It is the therapy. Does that make sense?
Absolutely. Yeah, no, very well said. And again, as we'll wrap up today, Dr. Elizabeth Francis, thank you very much for being here. Inspiring. I need to go write something down. I mean, it's just, I hope people who are listening or feel as inspired as I am, because I think the work that you do and the vision that you have for this profession is here to stay. So thank you so much for sharing that perspective. And those of you listening, look for a new episode, Peplau's Ghost, coming out soon. Please, again, like, subscribe, send those comments. We want to hear from you as well. Please, we'd love to hear, people that you may want to hear from in the future episode. We're happy to hear from that. So, all right, until next time, take care. And
carrying the torch through the blood and the rain. We are nurses, the world can't forget. We give our all, no regrets. Modern in our ways, but our roots don't decay. Nurses anthem, and it's here to stay. We are nurses.
So here's to the hands that heal, the hearts that stay steady, the voices that whisper you're not alone. Because nursing isn't just what we do, it's who we are.